Hi, I'm Dr. Bill Wyatt. I'm a general dentist, but I've done nothing but orthodontics for the last 45 years, and I teach orthodontics in the American Orthodontic Society. This is a organization of dentists that are dedicated to teaching general and pediatric dentists, or really any other dentist, orthodontics if you're interested in learning it. We have a very good organization. It's one of the largest in this area in the country. Uh, we have a good staff of teachers that teach all aspects of orthodontics. The stuff we teach is usually pretty solid, and we have an awful lot of people that come in and take orthodontics. And if you're doing orthodontics, it's good that you uh, get in an organization like this. We have yearly annual meetings. We have a board certification that people go through. And if you can pass the boards of the American Orthodontic Society, you can doggone sure do orthodontics. You can get in it and you can go as far as you want to go. Do whatever you want to. But it is a good organization, and I want to stand behind that. Now, I'm going to talk this morning about temporomandibular joints and some of the problems that people have with it. I'm going to show you three different cases here. All of them are women. About 80% of your TMJ work will be in women, but there are about 20 or more percent of men that have it, and some of them are very serious, and I'll cover some of that too before we finish with these lectures. The three women that I'll be showing this morning, one of them worked in the office for a long time, was very good assistant, and she also learned an awful lot about TMJ work too. That's now I worked probably for the last 25 or nearly 30 years doing temporomandibular joint work with orthodontics. You see, I worked with a Dr. Charles Holt who specialized in TMJ problems with people, and he would refer the patients over to me once he got them comfortable and positioned, and now want me to position their teeth so that they interdigitated and fit in the place where he had their jaws located, and they were out of pain there. So I'm going to discuss TMJ stuff probably on just a separate video, but we'll mention different aspects of it while we're showing these cases here. This young lady worked for me, and she just had a joint problem. Her joints were giving her trouble, and she was having trouble with that, and she had some dental problems also as far as orthodontic, needed some orthodontic work. So we kind of mixed the two together, but normally we would start out and correct the TMJ problem with a splint first. So this is the way her mouth looked. It looked pretty good. Now this was 1987, and you can see what's going on here. She's got a, by the way, her name is Carol Bates, and she worked for me, and I left it on these two records, and I think Carol won't mind you knowing about knowing her name here. She had a good class 1 relation on one side of the mouth, and on the right side here it's a solid class 1, and most all of your TMJ cases are going to be where they slide their mandible back when they close. A lot of times their jaw will hit right here and then they'll slip back. And when they do, they compress the area in the retrodiscal tissue and have trouble. Now, if they relax their mouth and it closes, it'll close right up here. But when they bite too, they'll slip back. And those are the kinds that have trouble. Now, there's a lot of backslide situations where they don't have that, but that's what happens in a vast majority of the people. And if you let them relax and close their mouth will close at this point. And that's where you should set their teeth up. Now this makes orthodontics difficult because this is a class 1 case and we're going to have to advance her mandible a certain amount in here. Now on this side you're in class 1 to start with, so you end up advancing it and it's not good. That makes it a lot of trouble when you go in there to do that. Now the class 1 side right there. So on the right, the class left side now is class 2. So when you get into a class 2 case with a mild with a TMJ problem, it's just a mild class 2. A lot of times you will want to advance their mandible, and so you'll end up with a class 1 problem on one side, which was the class 2, and you get on the other side and now you've got a class 3 class 1 instead of a class 2 class 1. Now this gets confusing, but when you get into TMJ work in orthodontics, it is going to be difficult. You've got to think, I mean really get with it to do the orthodontic work for a TMJ case. It's very difficult. So your class 2 side, if you advance it up to where it's class 1, well then you just more or less leave it alone. But the other one, you've got to come in here, you'll bring it up to a class 3, and now you're going to have to come in there with some class 3 elastics and correct that problem. So we put class 3 elastics on a lot of cases like this, to pull this side back in, you see, so that you can fit this deal, so that it fits right down in there again, in the class 1 relation again. Alright, let's get on with the case. Not a very big orthodontic problem, but if you don't understand the TMJ thing, you just cannot deal with these cases like we have to with that have TMJ and an orthodontic problem. The first thing out, you've got to put them in a split that lets them close their mouth in a correct position, or where it's comfortable to the condyle. In other words, the condyle's sitting in here. You need to get that condyle in a good position in here in the jaw, in the joint up here, and you do that. Then the joint gives you very little trouble. Now, I've lectured to a lot of audiences and people, whereas you let everybody just relax their mouth. Now, I don't use all these fancy things to locate the jaw, but just let the person locate the jaw where it wants to close. And mine's the same way, and I'm sure that most of the people watching this will be the same way. Now, if you lean your head backwards, your jaw won't go where it needs to go. Or if you lean it forward, it won't. But you've got to be in a comfortable head to shoulder relationship. And then just try to relax and let your jaw open and close, but don't, when your teeth touch, don't move any further. Don't push them together. Just let them open and close. And it's best they just don't touch. and just see where your jaw wants to go. And if you set a person's teeth up where their jaw wants to go and make the teeth interdigitate at the point where their jaw wants to close, there won't be too many of them that have TMJ problems. Now, granted, you have trauma and you have arthritis and you have the abuse of the joints, different ways, blows, and accidents, all sorts of things can go about, and stress. So when you deal with someone with a TMJ problem, you've got to go back into their life. And I've worked on an awful lot of people in it with this, and we have succeeded in almost all of them of making them better. I can't get rid of the click in many of them, but we can make them better where they get along better in there and get them out of pain with it. And we've been able to do that with nearly everybody we went in there to. But sometimes you have to sit and talk to that person or let them talk to you and tell you what's wrong. Now, most people with some kind of TMJ problem have 2 or 3 causes for them. They're stressful, they're working 2 jobs, or they're having divorce problems or family problems or all sorts of things that go on that are stressful to people, and they come down with TMJ problems, and they have a problem too with the jaw position. But if you get the jaw position right, they can stand a lot more of these other stressful matters in life than a lot more than you can if you've got a bad jaw position. And where this condyle is squeezing the retrodiscal tissue back here, this is where your synovial fluid and that's where all the blood vessels and nerves are, back in this area back here, see. So if you take care of the jaw position, get it out front where it's got plenty of room back here, then people can deal with a lot more stressful situations than they can normally. I'm just saying that's what I've learned over a period of about 30 years dealing with people. You don't have to have all these fancy appliances, or I don't. I can sit down there and talk to these people, and they can talk to me and tell me what's really giving them trouble. But you got to sit there and talk to them sometimes 30 or 40 minutes, to really figure out what's giving them the problem. All right, so much for that. I'm going to go ahead here with Carol. Now, she's got a jaw position here that's class 2 on the left side and class 1 on the right. And when you advance her mandible and get her jaw where it wants to be, then it ends up being on the left side. It will bring this jaw on out to here, and it'll be a class 1 on the left and a class 3 on the right, instead of a class 2 on the left and a class 1 on the right. That sounds crazy, but you'll have to work with it a while and figure it out. But don't think that you can do orthodontics and not be involved at all in TMJ work, because that's just impossible. Because you don't have lots of cases that have TMJ problems. All right, here we go. Now, Carol had a rather narrow arch. You see, it goes out here. And on the top, there was no crowding to speak of at all. It looked pretty doggone good. On the bottom, we've got quite a bit of crowding down in here. And so if you straighten this all out and don't take any teeth out, then this is going to be protrusive. Well, since she did not have, she's got this narrow jaw, and she's got the TMJ problem, I sure didn't want to take any teeth out. So I tried to figure out a way that we could accommodate the teeth without taking any of them out. And if I straighten these out on the bottom, it would be too protrusive, or narrowed or widened her arches out. That would help, but not to go through like you would think here. So what we did in Carol, we put some real large arch wires on here, and we broadened her arches out. If you take the arches and move them out this way, you can move them in this fashion. That's just the way it works. I mean, so we broadened her arches out, and that brought them in the front, and we were able to line up these teeth without making her protrusive. Now that's a little trick probably a lot of you have never tried, but it does work. Now, here we are. We've gone in and widened this out, and I left some space in here, and I'm crowding this one in. I kind of messed up the gingival tissue right here. I'm sorry for that. We'll get a hold of this and torque the root in, and that will help this place right here. You can watch it as we go through the case. Okay. This looks good here. No problem. We're lining this all up. But prior to doing all of this, we put Carol in a splint. I didn't show any pictures of that. And we brought her jaw out, and we knew exactly where we wanted to fit the teeth together. Now, you get that from the splint. So if you're going to treat TMJ cases and do orthodontics, which you almost have to do if you really get into it, then you really should treat the TMJ first and then come back and do the orthodontics. That's just the best way to do it. Now, once we get the jaw located, then we have to wear class 3 elastics or class 2 or whatever it takes to go in and line and coordinate the arches and get them fitting together better. Now sometimes you've got to keep the back teeth apart back here, so we put a little ramp like thing in the front to keep it off, kind of like the splint. You take the splint apart. Now that's saying a lot. You put somebody in a splint, you locate their jaw where it needs to go. Now, you've got them comfortable there. They're using a splint and they don't have any pain anymore. And you say, okay, this is good. You can take the splint out and the jaw starts hurting again. Put it back in, it stops hurting. Now, so you just figure that you have finally located where the jaw wants to be and where it's not painful at all. And now you've got to make the teeth fit in this new jaw position. Now that's where the rub comes in. That's where you separate the men from the boys, because you got to be able to move one side of the teeth back or one side forward, something to get them to interdigitate. So there's a lot of little tricks to using that. Sometimes one of the tough cases I got, Dr. Holt sent to me, was a woman chiropractor who had an absolutely gorgeous set of teeth that were perfectly class 1, and everything was beautiful and class 1. And he sent her over there to me and said, well, you've got to advance her mandible about 3 millimeters or 2.5, something like that. We had to advance the mandible for her to be comfortable. Now this is a beautiful class 1, and you advance it 2.5 millimeters, and you're going to screw up the interdigitation royally. So how are you going to do that? And it was very difficult to do, but we figured out ways to do this. I did that before I ever saw the lady. We went in and we stripped all the teeth in her mouth. We just strip the teeth back in here. Now, you want to advance the mandible, so you close the space that you have gained stripping from the back to the front on the bottom. Now you strip the upper, and you close the upper from the front to the back, and you will reposition the teeth a couple of millimeters or something of that nature. In addition to that, you can tip the teeth. I'll have to get over here to where we look at the side of the jaw. Now here we're expanding this woman's mouth out. We're using two of these big daddy arch wires. We're just broadening the mouth out, and that made the front go in, brought the sides out, you see, over here, and we kept her from being protrusive. I had to stick that in here, but I'm trying to get a set of teeth where here this will do. If you tip these teeth right here, the start back here with the cuspid, and tip them back, see, if you tip them back, they will make the mandible move. The mandibular teeth actually move back, and you tip these forward, and they will move forward. So then that way you can change where the teeth interdigitate by tipping the teeth and by stripping the teeth. And this is a neat trick. I've been to lectures that told all about this and didn't have any foggy idea how they were going to get these teeth to fit together. Now this is not simple orthodontics, so you don't jump on a case like this to start with. You got to be difficult. Now you have them brought forward in a splint, and now you take this splint apart and you keep the front part out here. You build this little ramp, and it keeps the teeth in this position, and you go back in this area and put something over that's in the top. You've got this little ramp, and on the bottom part of the mouth, you cover these or keep them covered and let this tooth over erupt. And when it over erupts and it's taking the load, then you take this off, and you've got them biting on the ramp out here in the anterior part of the mouth, and you've got them biting on this tooth, and you keep them that way for a while these teeth come together. That's the way you take care of the space. Now this is going to be kind of hard for anybody to just grab. This is not regular orthodontics now. So we widened the arch out, and that made the front teeth go in and the side teeth go out, and we kept her from being protrusive. And you can look at her face, she's not protrusive, but she did look protrusive. You take somebody with these little narrow arches and they're crowded, and you line them up and don't widen the arch, then you either got to take some teeth out, or they're going to be protrusive, or their lips will come forward regardless. So you've got to widen them out to do that. Okay, here we've changed the shape of this. We'll try to show you this. Now here we keep these teeth touching the ramp that's the same height as this splint. We keep something over the bottom down here. So you've taken your splint, you got a top piece up here and two lower teeth down here, and that keeps the same height. This is the same height as this is, and this tooth you take it loose and you let it erupt up. Now you've got to cut it loose really to do that. We didn't do that in this particular case, but that's the way we got these out. Now once this tooth is taking load, these teeth are still taking the load, then we take this acrylic off of these teeth right here, and now they come up and come in contact, and we assume that you have gotten the teeth in position so that they're going to erupt into interdigitation. So this is what you have to do to come out of a splint. In other words, somebody comes into you with this pain. They have other problems too, but you can get their jaw joint forward in the socket, and the big majority of these people will get where they just don't hurt that much, unless it's some bad arthritic condition or some trauma that they've suffered. All these things you have to take them into consideration in treating these cases. Now this is the way you come out of that. And so when these teeth are taking a load, then we can take this acrylic off, and your load is here and here in the front part of the mouth. Then these teeth will erupt together, and when they come together good and strong, sometimes we'll take one of these pads off and let these erupt all the way, and then come back and take the other side off. Sometimes you can do both of them, but you've got to have this posterior support back here, and then you have to have the anterior support in the front part of the mouth. Now this is not first grade orthodontics, I can tell you. And most orthodontics do not mess with this, but it's a necessary part of orthodontics if you're going to treat everybody. Now, we never turned anybody down. I mean, we took them. I've had people in their 80s, you see, straightening their teeth. Lots of them with TMJ problems. So this is involved in orthodontics. So don't think you're just somebody's not going to be touched with it. You will be. You may not know it, and you may not know what you're doing a lot of times, but you will be involved in TMJ orthodontics. And whoever came up with the stupid idea that orthodontics had nothing to do with the TMJ, that is absolutely ridiculous. Okay, now here back at the back, it was a problem with the Carol. We tried to jack the tooth up with the archwire. You don't need to do that. Just cut your archwires right in here and leave this tooth alone and that tooth alone. These teeth will take a load, and this tooth will erupt up and come in contact. When it's touching good, then you can take this acrylic off right in here, and they're also touching out in front. By the way, this was taken before we started using gloves altogether. So that's the way we came out of that in Carol's case. This probably is not going to be sufficient to teach you what we did. Now these were widening the arch out at the same time we were doing the rest of it. And that's pretty complicated stuff, so you don't have to do that. We just cut this arch wire right in here. These two wires were widening the arch, and then we let these two come together, and we're taking a load here and a load in the front part of the mouth. And when this gets together, we will take this acrylic off in here, and then you still are biting in the front on the palate, and we end up then leveling the bite out. These teeth will come up right in here. So hopefully you can get some sense out of what I've said here, but it works. But it's not simple orthodontics, I can guarantee you that. So anyway, we finished Carol out, and things looked good, you know. And see the mouth is widened out. This is back, lined up. This tooth will get a little better as she goes along. We turned it around and didn't get it torqued quick enough in there, and got a little gingival problem there. And so the case will be pretty much interdigitated at that position. See, both those customers, if you look straight at them, are going right down in the deal. Anyway, Carol uh, left. Her and her husband moved out to another town out west of Fort Worth a ways, and she went to work for an orthodontist in there. And I think Carol knew more about the TMJ problem than the orthodontist did, you see. Now this was the class 1 side to start with, and it's still class 1, but we had advanced it out to here, so we had to pull this. In other words, we had to get this back into a class 1. It was class 3, you see. So we had to come in here and pull this back in to correct that problem. Now this side was class 2, and it's pretty well class 1 right now. Not perfect, but it's pretty good. And we put her in a retainer with a bite plate. Her bottom teeth touched that, and that's where she did with a splint, you see. So this is where we were taking pressure at one time and pressure back here on the second molars and letting these teeth erupt into the mouth while we were doing that. Okay. Now we bonded those 6 teeth, the 3 to 3, bonded on, and we held that for a good long while. But after a while, you don't have to do that. Now we have expanded this area right in here, but when we expand cuspids, we keep the roots behind the crowns, and you don't have that big problem of cuspids moving back together. But if you take 2 cuspids, stand up here, and you expand them like this, and now the cuspid's sitting out here, it's naturally going to come back this way. Now a lot of students apparently where they did this research just didn't take time to put that crown out there and then get the root back in here, see. If you put the root back in there, the crown doesn't have any secret message, anything that's built into your DNA that's going to make that cuspid crawl back over there. It just doesn't have it. So you can expand cuspids if that's all that's pushing on them. That will not go back. And I've shown, I had that one case for 20 years, I've expanded. And Carol, if you could find her today, she's probably around here somewhere, I could find her. I'll bet you $1 to hold a donut that her cuspid teeth are still back there. And that's been several years ago. That's 1990, I believe, here, when we did that. And there's her profile. She's got a perfectly fine profile. When I first tried to expand those teeth, her lips were pushing out too much. And so we went back and widened the arches out. And this is a little trick you can do if you don't want to take any teeth out and you want to have, especially the TMJ problem, you can just widen the arches, and that helps it. Now that's a good profile, really, quite good. And Carol knew a lot about orthodontics, and she went to work for this orthodontist out in, I think it was the town of Granbury. And she knew when he was doing something wrong. She went and told one of the patients he was going to take a bunch of teeth out on her, and she was an elegant lady. And she went out to her car to leave, and Carol went out the back door, went out to her car and said, "Don't you take those teeth out." Said, "You go into Hearst and see Dr. White." And she came in, and we actually straightened her teeth, and she had a beautiful set of teeth, a beautiful face. And she even sent her daughter, who was grown, in for us to do her work from there. And so I told Carol, I said, "Man, if this orthodontist finds out you did it, he will fire you straight out." But she anyway went out and told that lady, this tooth has still got a problem. And so that was something I did by not torquing that tooth in quick enough, you see. If I'd have gotten it in quicker, but sometimes it's hard to torque a twisted lower anterior tooth, and you will tend to strip them when you rotate them around, because the tooth is wider, it's mesial distal, and it's a lot wider than it is from right and left, you see. Okay. And this is the way this case has been for years. And she doesn't have any TMD problem anymore. Now here's the way we retain them. This is an 036 wire here. It goes out, comes around the last molar, comes up into the palate way up in here. This is an 028 round wire. I do not like the flat wire. Round wire will touch just on one spot, and you want to have it touching all these teeth. You've got an expansion loop in here, or you can do either way you want to with how you deal with this loop. You can tighten it up if you want to. That's the way we make our retainers. We never run anything under the, you say, well, how do you keep it in? That thing will just stay in by vacuum. But if you had any problem, you can come out here and put a little tiny wedge of a good composite underneath this wire. Sorry for that thing. But you put something under the wire, just a little bitty angle, see, and you'll have to snap that wire over it. And I can put these things, I can fix them where you can't or take them out of your mouth if you want to. So you don't need any clasp under these retainers whatsoever. And need to get all that erased. All right, when you finish somebody who you have advanced the mandible, you need to put some type of retainer excuse me, in there with a ramp on it that holds the jaw right in that place for a long time after go. Now we frequently on these TMJ cases where we've advanced their mandible very much, we will make an upper retainer. Whether they do it all on the upper, you can't already hold the jaw forward on the bottom. But we put an upper retainer in there with a big ramp at night. And during the daytime, we make one with just a small ramp where they're used to putting their teeth right in this groove right here, and then they continue doing that. And they wear that long enough. Actually, the jaw, I've had the condyles and the fossils actually change shape over a period of 15 or maybe more years, and then they won't go back at all then, and their teeth fit interdigitate good at that point. So this is the upper arch. Let me see if we get something here and compare them. This is Carol again here. Now this is her in 1987. And let me see. And here she is in 19 or something. It'll show up there in a minute. But that was, look at the width of that arch. And you see, when she smiled here, you see kind of a dark spot in this area. Now, when she smiles there, you don't. I mean, this is broadened out. And it brought this in and brought this out over here. And this is one of the nice things about it. You can expand the bone structure in an adult, any kind. And if you go with a group of teeth, you will move the bone with them. Now this is not thought to be proper, but that is actually a proper thing, and it does work that way. Now here's the way it was to start with. This was class 1 to start on this side right here. This was 87. There it is, 96. That's 9 years later. It's still class 1 right there, see. Now we'll go on to the other side of the mouth. See, I don't think I did anything there. You come over to the other side. Alright, in 1987, this was a slight class 2 side. Now she's got a TMJ problem. Probably she would never have done orthodontics if she hadn't had the TMJ problem. But if you're going in there to correct the TMJ, you might as well do the orthodontics too, because then you have to get this thing where it interdigitates out there, and that's what we did. Now you watch this side. This is 96 or something in there, and now it is interdigitated at this point too. Then Carol has gone on for years now with no TMJ problem. She understands how it happened. She wore a retainer for years, and her bite is not deepened. That's the way the upper arch looked to start with. There's the way it looked after. Now granted, that's blown up to some extent, but this is wider than the other picture's wider than this one, you see. Now on the bottom, now there we are with the, I guess that may be the nighttime retainer with a big ramp. We had a different one. Now this is the bottom arch with the crowding and the narrowness. You see how narrow this arch is. I'm sorry, I didn't mean to draw that way. Now watch where these cuspid teeth are, something like this. Now I'm going to go to the other one, and that's 96, and that's definitely widened out. Sorry, that thing wears the life out of me. I don't know how to stop it. Alright, those cuspids are wider, and they've been that way ever since we've done this. And when you take the 3-3 off, these cuspids aren't just going to automatically go back over here. If you put the roots down the way they ought to be. Okay, and here's Carol now. So this went off real good, and Carol has gone for years. She worked for me, I'm sure, 10, 12 years after this, and then she went to work in Granbury, and I still kept up with her, and she never did relapse back. So we'll just pause this. I'm just going to finish this video with this case, and I'll come back and do a second one and cover the other 2 cases. I've already spent too much time on this, so we'll close it out at this point. Thank you very much.